Type 1 diabetes is going through a very exciting phase. We have seen a dramatic improvement in the quality of life of children with diabetes much before the discovery of insulin, when diabetes was actually a death sentence, to the development of different forms of insulin and different delivery modes, to now what we're looking at is possibility of a closed loop or artificial pancreas. There have been huge changes in this regards, and many of us think that we have probably reached the peak as far as discoveries are concerned with regards to type 1 diabetes. But whenever we think that we have saturated the sort of inventions, we are always reminded to be grounded. And this is a very famous quotation from Commissioner of U.S. Office of Patents way back in 1899, when he said that everything that can be invented has been invented. And clearly, it will be foolhardy to believe that there would not be dramatic change in what's going to happen in terms of management of type 1 diabetes over the next decade. If you look at in the last 10 to 20 years, there has been a huge change, and we can expect that trend to continue. So what we really want in terms of diabetes management, which we are missing now, first obviously is to have a robust model to predict the development of diabetes. Having done that, you would like something to prevent its progression. Once diabetes is established, we would like to have ways in which we can replace the beta cell mass. And finally, we want to restore the normal physical activity or beta cell activity in that regards. So we'll just touch base as to what is happening in this regards in different fields in this proposition. So just to have a background, we all know that type 1 diabetes occurs in genetically predisposed individuals who are exposed to some trigger event which causes an immune destruction, resulting in gradual loss of beta cell function. And we have different phases which happen with regards to the beta cell function and the clinical presentation. So we have a phase in which the insulin secretion is normal, but the antibodies are still present. So individual does not have any symptoms or hyperglycemia, but the destruction process is happening. Then comes a time, maybe around 90% destruction of beta cells, when the insulin levels actually tend to dip. But at this time point, they are enough to have normal glucose. Subsequently, when the damage continues, we have a phase in which the glucose levels tend to become high, and it's that point probably around 95% of loss of beta cell function when you're talking about development of diabetes. And this is what happens in terms of over diabetes. This is also a continual phase, in that the initial phase we will have some C-peptide secretion, which will say that there is endogenous insulin secretion, and this has significant implications because individuals with type 1 diabetes who are producing C-peptide have a lower risk of hypoglycemia, lower insulin requirements, and do better than those who do not have C-peptides, which basically means it's the end stage. So depending upon the different phases in the life cycle of an individual with type 1 diabetes, we can think of various interventions which can be done. So clearly, in individuals who are genetically predisposed, we can think of doing a primary prevention strategies. After the damage has started in the form of formation of antibodies, we can then think of a secondary prevention strategy, which would basically be in the form of trying to delay the development or trying to actually stop the progression of autoimmune destruction. Individuals who already have had damage as far as the beta cell function is concerned, but still are producing C-peptide, we like to do something to preserve the C-peptide function with us of the various beneficial effects as we talked about. And finally, we may think of situations of replacing or restoring beta cells when it is too late. Unfortunately, when we look at the overall picture, we have patients who typically present somewhere in this situation of high glucose levels, and typically if somebody comes to us with DKA, we are talking about a situation when the C-peptide levels are very low. So all these primary and secondary prevention strategies would work only in very high risk populations or in individuals who have a strong family history of diabetes. Mostly we are focusing on things like replacement or restoration at the moment. Having said that, we'll now build up this famous story of inspired from Bollywood, the Sita Gita story. So we have a girl, 7-year-old girl who's been diagnosed with type 1 diabetes with TKA. She is being managed on insulin, doing well, but she also have a younger sister who is 4 years old. And parents are very scared as to what will happen to this younger child. And they want to know, to predict whether she's going to develop diabetes, and if yes, how much time. So in this regard, when we talk about type 1 diabetes prediction, we are looking at three basic aspects. We are looking at genetic predisposition, we are looking at immunity and development of immunity, which will mean that now the time has come when the damage has started, and this individual is at a high risk of developing type 1 diabetes, and also to look at clinical risk factors, which will tell us the rate in which the disease will progress. So in a genetically predisposed individuals who has developed immunity and has a clinical risk factor, we need to know when the child is going to develop diabetes. The best way would be to look at beta cell function in this regards. So what are the options to look at in terms of prediction? We can look into the HLA markers, or there are some non-HLA ways of looking at genetic predisposition. We can look at immunity in the form of both antibody based and CMI based immunity, having understood that the predominant mechanism of beta cell destruction in type 1 diabetes is cell mediated immunity. It is, however, much easier in a bigger scale to perform the antibody estimation, and that's why antibodies have become the primary way of predicting diabetes in this setting. And of course, we need to look at clinical risk in the form of age of onset, relatives being affected by diabetes, and a body mass index in that regards. Regarding beta cell function, we can look at the insulin secretion or the C-peptide secretion, or we can look at messenger RNA excretion as far as development. And in this regard, it's the antibody which actually forms one of the primary way to look at, which will give us the autoimmune status, and the insulin secretion as reflected by C-peptide gives us an idea about the situation in terms of the actual beta cell function. And it's these two parameters which really help us predict the development of diabetes in this regards. And in this regards, these two parameters are the key to evaluate the risk of development of type 1 diabetes in any individuals. And therefore, when we look at really the preventive and predictive strategies, there has been significant improvement in the way we can predict development of type 1 diabetes to a great extent. And studies have clearly shown that when we look at the antibody positivity, particularly the GAD antibody and the IA2 antibody, we would be able to predict in substantial number of individuals. So if you have a single antibody which is positive, the risk is basically around 2.5 to 3 times. But when you talk about both antibodies being positive, the risk goes up to 83 to 90%. So autoimmune markers are good way to really look at in terms of prediction and development. And it is clearly shown that having 2 antibody positivity means that nearly universally by around 10 years of follow-up, the individual will develop diabetes. And if we really combine a marker of beta cell function like C-peptide, or if we are able to document any impaired glucose tolerance or a slightly high HbA1c, that prediction becomes even more perfect. So now we have got very robust ways to really predict the development of diabetes, and one thing which has really helped is the electrochemiluminescence based assays for the antibodies, because conventionally what we have been using is basically radioimmunoassays, which had significant issues as far as the user interface and as far as predictability. But once the electrochemiluminescence assays were used by the trial net population, they found much better prediction model as compared to usage of the radioimmunoassays. So with the current sort of assays which are available, we are at a very strong footing as far as prediction of development of type 1 diabetes is concerned. So now what happened with Geeta was that she was found to have multiple antibodies positive as far as autoimmune functions are concerned. She had a reduced first phase insulin response, indicating that probably she was not producing enough insulin at the moment. So that gave her around 90% 5-year risk. So now we know that she is pretty much sure to develop diabetes. The parents' next question is, can we prevent this disease? And here is the sad story. while we are able to predict with quite amount of confidence, there is hardly any preventive strategies which have been found to be effective. There have been lots of trial in terms of primary prevention in those who do not have antibodies. There have been studies of gluten-free diet, hydrolyzed formula as against cow's milk, use of DHA, and all of this has not been found to be effective. There have been secondary prevention strategies in individuals who have already developed antibodies using either oral or subcutaneous or inhaled insulin, using nicotinamide, and they have also been found to be unsuccessful. So at the moment, we do not have an effective way to prevent development of diabetes in individuals who are at risk to development. There is a lot of trials which are going on in this regards, and I would refer all of you to really follow up periodically this international website of Diabetes Trial Net, which is really looking at in terms of risk assessment, family screening, and preventive strategies for type 1 diabetes, in which a lot of work is going on, but we don't have any concrete data as far as an effective preventive strategy, unfortunately, at the moment. So what happened after 2 months for the girl with diabetes, that is Sita, is that she went into honeymoon phase. She required very little amount of dose of insulin, and parents were very happy and they wanted this phase to last. So we thought we'll have a look at the C-peptide levels, which were found to be pretty alright as far as the function is concerned. And how do we really do in terms of prolongation of honeymoon phase? And this again is a desirable goal, because continuation of C-peptide secretion, as discussed earlier, is associated with better glycemic control, lower insulin requirement, and lower rate of hypoglycemia. So there are strategies which have been developed as far as preservation are concerned, and they have used immune mediators like anti-CD3, teplizumab, antibodies like abatacept, and antigen-based strategies like GAD to sensitize the body to really have lesser immune response. But unfortunately, most of these studies have found some improvement for a small period of time, which usually goes over time. Another thing is to remember that we need to hit hard and hit early, because if we delay in all that, we may actually miss the port by the time it happens. And unfortunately, somebody presents with DKA, the chances are that we already missed the port in this regards. And that highlights the importance of early identification of type 1 diabetes. So 1 year later, Sita now is off the honeymoon phase. She is requiring around 1 unit per kg per day. She is sick of injections, and they want alternative strategies to do in terms of management. So what can we do in terms of replacement which is non-injectable in this regards? And the alternate routes which have been used, there are multiple options which are available, including the nasal, the buccal, the inhaled insulin. And the advantages of many of these is that they are actually going to bypass the portal system, because insulin is actually going to act in the portal system. If you're giving it subcutaneously, it's going through the liver and going again back. It is unphysiological way of giving insulin. So the theoretical advantages of many of these are that we are actually bypassing that portal system. The only one which has been found to be reasonably case-worthy to use in clinical practice has been inhaled insulin, and we all know about the Exubera story. Unfortunately, it has been taken off the market, and now recently we have the newer inhaled insulin in the form of Afrezza, and there are definite trials which are going on for prevention with inhaled insulin, but to the date, I would say it's a work in progress, and we need to watch the space in this regards as far as non-injectable insulin delivery devices are concerned. 3 years later, she is on a basal bolus dose, has become obese, HbA1c is high, so she's already entered puberty, and now she has insulin resistance, and this causes a real problem, because if you increase the dose of insulin, she's going to become more obese and cause, it's a vicious cycle in that regard. So what are the options which are available? And in this regards, we are now going to talk about the non-insulin options which are available for management in type 1 diabetes in the form of metformin, SGLT2 inhibitors, and GLP-1 analog. So just to form a template for that, we know that the blood sugar can be tackled in a patient with diabetes predominantly via acting on 3 organs. We can act on the gut, which actually is involved in absorption. We can act on the liver, which produces the glucose. And we can act at skeletal muscle, which actually is a good consumer as far as the glucose is concerned, or rarely kidney, because which is one player which has now been found to be effective, which causes excretion. So it's a balance of the glucose which is produced from the gut absorption and the liver, and the one which is actually lost in the form of skeletal muscle and kidney. And in this, clearly we know that pancreas is the key organ which is regulating predominantly through insulin, causing hypoglycemia, but also through glucagon, which will cause basically hyperglycemia. And sometimes it is not only insulin deficiency but glucagon excess which may play an important role as far as the development of other complications and the cause of hypoglycemia in this setting. So therefore we need to act on any of these strategies to improve the outcome in this regards. And in this regards, the gut now are known to play an important role by secreting incretin, which not only increases insulin secretion, which may not be relevant as far as management of type 1 diabetes is concerned, but also suppress glucagon, which is an important cause of hyperglycemia in these individuals. We therefore can now think of different agents as to how they can possibly act in type 1 diabetes. So clearly metformin is one agent which inhibits hepatic production of glucose and could be effective. We can think of amylin analogs which will actually delay the gastric emptying, so therefore the absorption of glucose will be less. We can possibly think of agents which act through the GLP-1 pathway using the incretin to in a way suppress, produce insulin which is not effective in type 1 diabetes, to suppress glucagon and to have an effect as far as gastric emptying is concerned. One exciting way of managing diabetes is to use SGLT2 inhibitors, because what they will do is that they will cause the glucose to actually get excreted in the urine, and therefore there will be less load on the pancreas, so to speak, to act. Alternatively, we can think of thiazolidinedione in this regards. Now, if you look at these agents, what we need to remember is that we are talking about an obese individual who is at a risk of insulin resistance. So TZDs have a theoretical risk of weight gain and are now not one of the most popular agents in this age group. So that will be out in that perspective. Amylin is a small player, maximum 0.3 to 0.5 HbA1c reduction in that regard. So we are focusing mainly on the three agents: metformin, GLP-1 receptor analogs, and SGLT2 inhibitors. So what about metformin? A lot of people use metformin in type 1 diabetes because we assume that there is a lot of insulin resistance in individuals at that stage, and in overweight individuals, if you use metformin, it will be effective. So there have been various studies which have looked into, and what they usually conclude in most cases is that its role is predominantly in obese individuals, particularly if they have associated findings like fatty liver or polycystic ovarian disease. The benefit is modest, maybe around 0.4 to 0.6 as far as HbA1c is concerned. But one thing we need to remember in all these trials is that when we are managing an individual with type 1 diabetes, it's not only the HbA1c, but the insulin dose which also makes a difference, and the weight which also makes a difference. So if we are actually reducing the insulin requirement, automatically the HbA1c will be the same, but you're reducing the insulin requirement, and that will actually have a beneficial effect. Similarly, 1% reduction in HbA1c is offset by the cardiovascular risk of 3 kgs gain in weight. So losing weight is also in a way looking at helping you in terms of improvement of glycemic control in that regards. What about GLP-1? And a lot of studies have gone on to exenatide and liraglutide in that regards. I won't go into them in detail. What it shows is that on an average, a 6-month treatment will give you around 3 to 5 kilograms of weight loss, which I said is equivalent to around 1% HbA1c reduction if you look at long-term cardiovascular risk. The insulin dose comes down by around 20%. And the HbA1c comes down by around 0.3 to 0.4%. So basically what we're looking at is that it's actually helping. It's like a sidekick which is helping insulin in this regards. And what about SGLT2 inhibitors, which are the new kid in block, which basically cause increased excretion of glucose from the kidneys by shifting the renal threshold to the left side. So for the same level of blood sugar, you will have much more sugar which will come in the urine. So we expect around 60 to 100 grams or more loss as far as glucose is concerned, and therefore the load on pancreas will be less. And primary studies have shown short follow-up that there is improvement as far as weight loss and some reduction as far as HbA1c to the tune of around 0.5%. There have been a few studies in which it has been associated with DKA, an interesting way being euglycemic DKA. So what's happening there is that by giving SGLT2 inhibitors, you're reducing blood sugar levels. But if you stop insulin, or if you're not giving enough insulin, the individual will be insulin deficient and therefore will develop DKA because of ketosis. The key as far as management in type 1 is concerned, as far as SGLT2 inhibitors is concerned, is to have reasonable dose of insulin, to ensure that there are no ketosis, to ensure that they actually have no osmotic symptoms, and then you add SGLT2 inhibitors and gradually reduce the insulin. The risk of DKA would be less, but these are just preliminary studies and we can't base data on this in this regards. So just to summarize the role of non-insulin based treatment in type 1 diabetes in the form of metformin, SGLT2 inhibitors and GLP-1 analog, they are helpful in reducing dose, weight and as an adjunct. So we can consider them as a sidekick. So now what happened 5 years later is that Sita is now on CSII with intermittent CGMS. In spite of all that, she is having fluctuating sugar. So what to do? And in this regard, she is already on an insulin pump. So we need to think about something else which will help. And that's why we always now talk about the new buzz in the town of artificial pancreas. So what really artificial pancreas is? And in the truest sense of the word, whatever we are calling an artificial pancreas is not artificial pancreas. It's a closed loop delivery system. Because pancreas is a complex organ. It has an exocrine part and an endocrine part. And even in an endocrine part, we have somatostatin, glucagon and insulin. So most pumps which are actually working in a closed loop system are actually working in a form of acting on only the insulin axis. Having said that, if that term is actually catchy and the phrase is catchy, it basically means that you have a device which is delivering insulin and you have a device which is measuring sugar and the CGM sensor and receiver that sends the signal which is integrated and gives a message to the pump as to what doses to be given. So there are ways in which we can actually use a CGM, continuous glucose monitoring system, and an insulin pump which acts like a pancreas. But as I said again, it is not an artificial pancreas because you are not measuring portal glucose and you are not really having other facts as far as glucagon is concerned. Having said that, Medtronic has now come up with a system which is quite close to the artificial pancreas, in which similarly you have the meter which gives the signal and then you have the CareLink software which helps the pump to deliver desirable amount of insulin which can actually be shut down once the levels are going low and can be increased when the levels are going up in that regard. This is going to come up very soon in the US market and would be a way forward in terms of management. Now, another way or another approach of using artificial pancreas is actually to use a dual chamber pump in which you have a pump which secretes both insulin and glucagon. So this is what it looks like. This is the iLet device which basically works in terms of both the insulin as well as glucagon source. So if the sugar levels are going low, it will not only reduce insulin dose but also push a bolus of glucagon because that will help in terms of maintaining the physiology. And there have been studies in adolescents in a small group for some time which show that compared to sensor augmented pump therapy, which is not really artificial pancreas and which does not give glucagon, bionic pancreas is associated with much better duration of stay in the normal range and lower risk of nocturnal hypoglycemia. So bionic pancreas is something which is going to be the buzzword over the next few years, I would expect, in that regards. So now 15 years after follow-up, she is sick of insulin and glucose monitoring and wants a cure in this regards. And this is a troubling question. Every time we actually are managing a patient, they come up to us and ask that, okay, is there something new in terms of cure? And as my learned professor told me a decade ago, that even from 80s we have been telling the patient that in the next 5 to 10 years there will be a cure for diabetes. And this has now been 37 years since 1980 and we are still not looking at cure. So the options which we have in the form of transplant, islet cell or stem cell replacement. Pancreatic transplant is a major endeavor. It is only recommended when you are doing renal transplant because of the autoimmune involvement and the immune suppressant drugs which are required. Survival with a simultaneous pancreatic transplant is better, of around 9 years, while those who have a subsequent transplant only stay for around 7 years. So if you want to do it when you're doing the renal transplant. So basically, hardly any role as far as pediatric group is concerned, because with newer management, we should not have children who are going into renal failure requiring renal transplant. So pancreatic transplant is off the agenda as far as management of type 1 diabetes in children is concerned. What about islet cell transplant? It's a easy procedure. You just inject it, take the islets, you use some protocols in which less steroids are used, and then in that regards you just push it off and they are replaced in the liver, and therefore they start acting as beta cells. And these protocols have been associated with a good remission with residual effect of few years, but it's not the real cure that we are looking at. So finally what we're looking at is stem cell therapy, and there are hundreds of centers across the country and abroad which claim that stem cell therapy is highly effective, but when you look at literature, there are only a few studies which show that the hematopoietic stem cells are the only one, the bone marrow hematopoietic stem cells, the only ones which have shown to be some efficacy as far as maintaining C-peptide levels and reducing the HbA1c levels, but these are just early days and we need to really look at in terms of long-term outcome. What is important to remember is that somebody who's developed DKA has a much worse response even to stem cell therapy. So again, the aim of the clinical fraternity would be to pick up DKA and pick up diabetes much before DKA if you want to really have an important option. As in many other areas of research, type 1 diabetes actually has been a story of one step forward and two steps backwards, and in this regard, one of the most fascinating discoveries, or what we thought as of beta-trophin, a hormone that controls pancreatic beta cell proliferation, was a big buzzword a couple of years ago, and we know about this study in which in animal models giving beta-trophin resulted in significant improvement of growth of beta cells. So we thought there's a way now to produce enormous number of beta cells in the lab. Unfortunately, the Douglas Melton group, which worked a lot in this regards, were not able to replicate the same findings in different age groups, and different experiments across the globe did not confirm in the same, and unfortunately this paper had to be retracted. So we are still at least a decade away from a cure, a magic cure for management of diabetes at the moment. So just to summarize the future of type 1 diabetes, we are very good as far as prediction is concerned, but not good as far as prevention. Non-insulin treatment is adjunct, particularly in obese individuals and comorbidities like polycystic ovarian disease and non-alcoholic fatty liver disease. Artificial pancreas may be the buzzword, and bionic pancreas may be something which may hear more often over the next 5 years. And stem cell therapy is clearly something which is going to work over the next decade or so as a viable option, probably, for cure of diabetes.